Welcome to the NETEC webinar today, where we're going to share with you more about the National Special Pathogen System. I'm Shelley Sweethelm, and I'm a nurse by background. I am the Associate Director for Clinical Management and Preparedness here at the Global Center for Health Security in Omaha, Nebraska. I also have the opportunity to serve as the National Special Pathogen System Executive Director. As we move through the presentation today, I want to discern a bit for you about what is NETEC versus what is the new NSPS. So NETEC, which is now going to be celebrating almost 10 years of work in partnership for preparedness, has the mission statement of really setting the gold standard for special pathogen preparedness and response across health systems here in the U.S., driving those best practices, closing knowledge gaps, and developing innovative resources. These are the 13 regional treatment centers that you see dispersed across the United States within each of the 10 HHS regions in the U.S. We want to draw special attention to this because it's very easy on our website, netec.org, for you to connect back to these regional treatment centers to get support, guidance, technical assistance, etc. So we'll be calling attention to these 13 regional treatment centers more as we navigate our presentation today. These are the 4 pillars of NETEC, the National Emerging Special Pathogen Training and Education Center. We provide consultation and assessment. We have several self-assessment tools. We do technical assistance, provide guidance, support. We work with those 13 regional treatment centers. If a question comes in from region 1, where Dr. Bittinger is located, we reach out to their team to partner with NETEC to really help and guide and assist those facilities. Education and training is a very significant product line for NETEC. We deliver both didactic and hands-on training. We do some in-person courses. We have several online trainings and modules that you can take to advance your knowledge on a certain topic. We compile a lot of online resources and tools. So don't ever start from scratch with creating a plan or a checklist or an algorithm. Please come to netec.org and we'll help you get started. And then we also have exercise templates. So if you're wanting to do an exercise on a special pathogen, just to better understand sort of the status of your organization and recognition of a special pathogen that might walk through your door, we have those exercise templates for your use. We also have a research network. Every time that there's a novel pathogen, or even though some of those that have existed for quite some time, such as Sudan Ebola virus or Marburg, we have a system in place where we have a central IRB, we have policies and procedures, and we can quickly operationalize the capability to provide an infrastructure for pursuit of providing those medical countermeasures that might be important to help mitigate illness for individuals with those pathogens. And then in addition, one of our more recent adds is international partnerships. We have numerous partners in the world now that are also focused on special pathogens. As we know, most pathogens start elsewhere, but that's not always the case. But it gives us a great partner approach to be able to understand more about the pathogen, what were their learnings in clinical care and supportive care, so that we can apply them here in the U.S. and share best practices amongst all of us. All right. So let's get started with a little bit of detail and information about the new National Special Pathogen System. So this will be our agenda for the next 40 minutes or so. We're going to walk through a little bit about the NSPS system and a little bit about the new minimum or essential capabilities within each of the levels of the system. We've got a very robust panel today, and then many of you submitted some questions for us to address, and they were great questions. We were very impressed with those questions that came in advance. Plus, we'll be looking at the Q&A. If we get to the Q&A today and there's way more questions than we have time for, we will give you our word that we'll get those answers and we'll close the loop back with providing that detail on our website most likely. So these are our objectives. We're going to discuss the organizational framework of the NSPS, including the roles within different facilities and the respective HHS regions. So what is the role of the regional treatment centers as an example, the role of NETEC, et cetera, how that contribute to pathogen surveillance, the outbreak, protecting our community and the patient and our workforce. The second objective today is to explore how healthcare facilities and public health entities have implemented the NSPS, and you'll hear from some of our panelists on how they're actually operationalizing the system of care and how those relationships and strategies have expanded and support each other within their region. This is our panelist group today, so we're excited to have them join us, and we'll introduce them a little bit more as we get started. All right, we'll just head on in here. So what is the NSPS? The NSPS is a tiered system of care. It's got 4 levels, level 1, level 2, level 3, and level 4. You can see that we've aligned the level verbiage with other national systems. So, for example, trauma or burn. So your level 1s are going to have a lot more accountability with outreach, education, training, and we'll talk more about that. With increasing capabilities from a level 1, and then we'll talk through the nuanced differences of each level as we move forward here. EMS and public health are significant partners. So I'll just put that out there for you all as we move forward here. So we've spent a lot of time on our mission and vision, and I feel like it's really important for us to pause today to really understand the purpose of creating this system is to provide a coordinated network of high quality special pathogen care. We saw the effect of being able to provide significant supportive care to those patients with Ebola virus way back in 2014-15 who came to the US. We also want to provide that care in a way that protects patients, protects our communities that we serve, and protects our healthcare workforce. As we know, COVID, other pathogens have really had a hard time impact on our workforce. So we really feel strongly that by creating this system, we're creating an infrastructure that allows us to really protect our workforce and our communities through this preparedness effort. So how will we know if we've really aspirationally achieved the goals? We'd have 0 preventable deaths from a special pathogen. We'd be able to mobilize a network to care for these folks within 2 hours. And we would have 100% access to care for everyone in the United States who needs it for a special pathogen infection. It's a busy slide, but I think it's important just to highlight a few things. So even though we're calling this, sort of a reinvigoration of the system, the tiered structure, for anyone who's been around a bit since 2014-15, we had a system, right? So in 2014-15, we didn't have really a whole lot of infrastructure. But what we had was some facilities who had done some planning and preparation for care of these patients, but really weren't acknowledged or identified as such until after we provided the care for patients with Ebola virus disease in 2014. In 2015, we were all running as fast as we could, right, to get up to speed, to get knowledgeable about how to educate and train others. We had then what was called by ASPR the Regional Ebola Treatment Network. So that included 10 regional treatment centers, so 1 per region here in the nation. In addition, they started NETEC, and NETEC continues to be NETEC today, 10 years later. So those then served as a foundation to then add what we called then state-based treatment centers. And then we also had assessment centers. So assessment centers were those places where we could hopefully provide care, get some lab drawn, discern whether they were ruled in, ruled out, and then move them accordingly. So as time goes on, and we know the ebb and flow of funding over time, the system sort of began to fall apart with the exception of maintaining the regional treatment centers. And many of you, from a state-based perspective, through HPP funds, were able to continue to provide support. And some of you do today with the SPTCs and assessment centers. So we couldn't continue the system without that support. But the system began to kind of fall apart. And then COVID happened. So very soon thereafter, ASPR, we rebranded what was the Regional Ebola Treatment Network to now have it be more globally focused on all special pathogens, not just Ebola. So as we see the pathogens in the world today, this makes perfect sense, right? So we rebranded, and then in addition, we were able to start working through some effort to begin to create a strategy for how would we reinvigorate the system of care, the tiered structure, again, in the nation. So we've been working on strategy and now implementation for the last year and a half. To get us to today, we now have 13 regional treatment centers, and we've got the NSPS system that we're very excited to tell you more about what that looks like today. So here are the 4 levels. So level 1 are those regional treatment centers, the 13, the hubs, and they're accountable for care for the duration, neonates to geriatrics, all acuity, and sometimes they partner with a pediatric facility to make that work from an all age group perspective. And they also are accountable then for the education, training, and outreach, similar to level 1 trauma centers. Level 2 used to be what we called state-based treatment centers. Now that's the special pathogen treatment centers. So these, and the reason we kind of took the word state out is that we're really hopeful that as we build the network, we can have people cross state lines if needed, and if it's closer adjacency, and getting people to that level of care that they need quickly, we could have more access to care for people. And these folks in level 2s continue to care for patients for the duration, but some of these level 2s may be a pediatric center only, might be an adult center only, or they might serve both. And really, we're asking them to care for fewer patients than the level 1s, and we'll walk through a little bit of that side by side. But level 3s then are continuing to be those assessment centers. So we want you to be able to stabilize the patient. We want you to be able to draw that laboratory testing, get it to your laboratory response network or your state lab, and then work on where are we going to place them, et cetera. And then level 4s is really all other healthcare facilities. So that's really a lot of facilities. And as we know with the new Joint Commission standards that went into place July 1, of which I'll just put a plug in, NETEC.org, a lot of information on how to better operationalize success in putting these standards in place for your organization. Now are required to have some basics related to special pathogens, identifying, screening, PPE donning and doffing, a plan for cleaning, and a few other things. So please go to our website and find that information if that's of interest. So when we talk about the difference between NETEC and NSPS, I want us to really think about NETEC as sort of the engine, the stuff, the support, working through how to education and training, consulting, putting the network in place for medical countermeasures, international partnerships. So sort of the engine to run the system. The system is the healthcare facilities. And the system also includes our EMS and public health partners that are essential to coordinate within the system. This is just a different way of looking at the hub and spoke model and how NETEC really provides structure and support for those pieces to the whole system. And then our level 1s are the blue dots that really have an accountability for that outreach piece and support within each region. This is a notional map. So we know it's not completely built out, and we know that we've got pieces missing here. But this is, to the best of our knowledge, some of the systems that are currently still in place that were part of the tiered structure before or have stayed, in progress to support special pathogen preparedness. So the orange dots are the 13 regionals. The blue dots are what used to be those state-based level 2s now that we're calling them. And then the green dots are the assessment centers. You see a bunch of gray dots. Those are the facilities or locations where we've connected and they've said, gosh, we can't do it any longer. Or we've let it go, or something to that nature, or I can't afford to do it anymore. So just know that gray dots are important to us and most likely will be part of our mission to do outreach to see whether or not you're willing and interested to rejoin the system at some point. All right, I'm going to turn it over to Dr. Paul Bittinger now. Dr. Bittinger, big role at Mass General, and I'll let you introduce yourself, Paul, but he has been my partner as we've really worked through creating the system of care capabilities.
Thank you so much, Shelley. And it's really my pleasure to join you and all our amazing panelists for this webinar. As Shelley said, I've been really so fortunate with her to lead the system of care group. And as we're going to talk about in a second, try and make it much clearer for everybody what it means when you say a level 1 or a level 2 or level 3 facility. And the hope is that by making it clear and in the work we've done otherwise, we're going to pave the way for more facilities to sign up as level 2 and 3 facilities. Really, the whole concept of the National Special Pathogen System relies on having hospitals that are accessible to their communities so that we can have the greatest amount of care capability for the country. So just by way of brief introduction, again, I'm Paul Bittinger. I'm an emergency physician by training. My day job is as the Chief Preparedness and Continuity Officer for Mass General Brigham, which is a large academic healthcare system in New England. But I also am the Director of the Center for Disaster Medicine, and as such, lead our Region 1, the New England Regional Emerging Special Pathogen Treatment Center. So we were really fortunate to have a tremendous number of people participate with us from across the country to discuss the minimum capabilities within the system of care. We had people from level 1 centers, regional centers. We also had people from what were in our level 2 facilities, level 3 facilities, and even smaller hospitals, including critical access hospitals. So we've tried very hard to capture everyone's perspectives. It's a common mistake to think you know what someone else's perspective is, and we tried really hard to have all the voices there. On this slide, you'll see the domains that have been identified, and what these domains are the specific kinds of capabilities that you have to attain to a certain level to call yourself a level 1 or a 2 or a 3 facility. Treatment and care is, of course, kind of the most obvious one. What do you have to be able to do in order to actually treat patients? But the training capability is how do you keep that treatment and care and safe care capability within your facility? So how do you train your nurses, your laboratorians, your security staff, your physicians, and what needs to be available to meet that capability of safe care at the right level? Personnel management, I think maybe all of you watching this webinar know how hard it is to maintain specialized teams over time. You have to track their training, you have to track their exercise participation. You have to be able to make sure that people stay in good standing with the team. And of course, all of us have people coming into and leaving our healthcare organizations. And so that's a big effort. Special pathogens work is one part of a hospital's emergency preparedness, and the interface with the hospital's emergency management program, with the local government, with the state government emergency management programs is key. This is not done in isolation. Even within the NSPS, there are local and state connections that are absolutely critical, and so we've talked about those. Of course, it's our hope, as Shelley said in the goals, to have 0 preventable deaths, but that doesn't mean it's possible to prevent every death from a high consequence infectious disease. And depending on the illness, particularly say for the viral hemorrhagic fevers, how you safely take care of someone who has died from their illness is a pretty complicated procedure. So what can be expected for decedent management? Waste management may be the hardest issue with certain kinds of high consequence infectious diseases. Those that are designated as Category A by the Department of Transportation and the CDC have the most stringent waste disposal requirements, and they can be pretty tricky. It needed special call out because we've actually found, again, talking to a lot of folks on the front lines, that can be a barrier to people's willingness to participate in this system. PPE, boy, coming through COVID, we're all very, very, very familiar with PPE discussions, but the PPE is different for some of the kinds of HCIDs, high consequence infectious diseases that we worry about. And so we have to have some standards on when and how PPE is accessible. How do people modify their physical infrastructure at the different levels is important. We've already had some questions submitted. We'll get to that a little bit later in our discussion about the laboratory capabilities. Many of us remember from 2014, 10 years ago, when the lab staff or the lab equipment managers nationally said, you can't run a suspect Ebola sample on the main hospital analyzer, or it'll void the warranty, or we won't ever service it again. So we need to talk about how lab testing is done and what are the minimum kinds of requirements. All of us in medicine have to be committed to generating new knowledge, especially in the infectious disease realm where there may be a new pathogen we still don't know about that emerges. We're going to have to learn a lot about it as quickly as possible, just like we did during COVID, hopefully even better and faster. And then lastly, it is obvious that this is about infectious disease transmission, right? That the whole network exists because there are these infectious diseases that are of greater consequence for a variety of reasons than others. And what we all are committed to is the safe care of these patients so that none of our staff, none of our patients get a nosocomial transmission of these diseases, that we deliver the highest quality care, but of course do it safely. So I'm not going to read through every one of these slides, but I'm going to touch on a couple of points. Again, Shelley said so very nicely, level 1 facilities think of as the level 1 trauma centers. They're the ones that have the highest clinical capability as well as the research, training, planning responsibilities as well. The difference between level 1 and level 2 is both a level 1 and a level 2 are expected to be able to care for an HCID patient throughout their course of illness. And for some of these illnesses, it could be 3 weeks. For many, it's much shorter. But the expectation is you can care for a patient with any HCID through the full course of their illness, both in level 1 and level 2. The difference is with a level 3, that it's the kind of facility that starts the workup. Many of you may remember back from the early days of COVID, the CDC described in their Morbidity Mortality Weekly Report that there were people who were thought to have COVID because of some epidemiologic risk factor and their symptoms, and they didn't get care. They didn't get antibiotics. They didn't get anti-malarial treatment. They didn't get IV fluids, and they died. There tragically are cases where we know that because someone raised the specter of an HCID and the safety concerns that come with it, patients didn't get the timely workup and treatment that they need. The vision of the NSPS, one of the important parts of the vision, I guess I should say, is that there are enough level 3 facilities around the country so that mostly, no matter where you live, there's a level 3 facility nearby. So if you have the right epidemiologic risk factors, if you have the right symptoms, EMS and your local system can get you to a level 3 facility, and they can start the IV. They can give the antibiotics. They can give the antimalarials. They can start the basic clinical care, and they can draw the diagnostic samples working with their state public health authorities, with the laboratory response network to begin and ideally complete the diagnostic process. So you're all pretty aware that most people don't rule in for HCIDs. They typically rule out. And so if we have a good network, and notionally we're thinking maybe 200, 300 of these level 3s, that they're close to most of the major areas around the country. Obviously, Shelley talked about both the importance of equity and the importance of considering the rural parts of this country. There are a lot of those, that we have level 3s situated accessible to rural America as well. But we have enough level 3s so that you, when you have those symptoms, can go to that kind of a facility. If you arrived instead at a level 4 facility, which is any other hospital, any other emergency department, any other urgent care, you can work with EMS. Shelley already mentioned EMS. We'll come back to it again in a second. It's a critical part of the NSPS, but you get transported to a level 3. They begin your workup, they begin your stabilization, and this is how we achieve 0 preventable deaths from HCIDs. Soon as you hopefully rule out at a level 3, then you become a normal patient and continue to get the care that you were getting. If in fact, though, you rule in, then you would move up to a level 2 or a level 1 facility, depending on a lot of factors. What's the closest facility? What's the load among the hospitals right now? Others. And so again, think of level 3s as those critical elements of safety nationally in how we're going to achieve 0 preventable deaths. Level 2, level 1, the key difference is a bit in size. And again, we talked about the education and the training and planning capabilities. The expectation you can see here listed for level 1 is at least 2 viral hemorrhagic fever patients or 10 patients with an airborne transmissible disease. The numbers are a little bit smaller for a level 2. Again, I promise not to read this slide to you, but there are differences in support of those big picture assumptions for how much PPE they're expected to have on site, how often they would conduct exercises, how often they would do training in either PPE donning and doffing or skills, and what lab capabilities they have. All of this as part of a system. The vision is done among the facilities that sign up in close partnership with their local and state public health authorities. And I mentioned EMS a couple times, as Shelley already did as well, both working with EMS authorities to come up with systems for transfer, and of course supporting the continued development of HCID capabilities within EMS. We know that it's not just hospitals and healthcare that have seen some loss of capacity in the last 10 years for HCID care. It's in the EMS front as well, and squarely in the center of what we're thinking about for the NSPS. So there's more detail behind that graph that we just showed you on the previous slide, and there's a lot that the NSPS is doing to make that more accessible, to make it clear to everyone. But we can talk a lot about it, and so Shelley had already mentioned that there are the 13 regional centers around the country. Every HHS region has at least one. You can go to netec.org and you can find your region's regional emerging special pathogen treatment center. There's contact information. You can reach out to them. And if I can sort of speak on behalf of my RESPTC colleagues around the country, I know that all of us are extremely excited to have these kinds of conversations with other hospitals in our regions and talk about both what the capabilities are and how we might partner to help more hospitals sign on at the level 2 and level 3 levels.
Hey, thanks, Dr. Bittinger. You know, one thing I want to reinforce that I failed to mention when I was showing that notional visual of the United States is that even in the trauma system 30 years later, right, we still have what we would call deserts, where there are no trauma centers within a close distance. We've got to continue to work hard on that, because truly where you get injured matters. And whether you live or die, you know, is kind of based on where that injury happens, based upon the system and how to quickly get to the next level of care. So the same goal will apply to NSPS. We're going to need a lot more healthcare facilities to join the system, to make all this work, to create a structure that's going to be successful for preparedness, for making sure that we protect our workforce again and our communities. So I'm excited. We're going to talk now and move on to our panel. And I want to engage Dr. Bittinger a little bit more to talk about the gaps that should be prioritized with the development of NSPS. And he's been very good about pushing on these gaps and talking freely about them. But one of the biggest things, and I'm going to call it the elephant in the room, is funding, right? So funding is a challenge for us, and it continues to be a challenge. And Dr. Bittinger, if you wouldn't mind sort of taking the lead on having a conversation about this topic and sort of what we're strategizing or trying to do to kind of close that gap.
Yeah, thanks so much, Shelley. I think, you know, probably it's if not the first topic on everybody's mind. It's maybe the first 10 topics on everybody's mind as far as how we're going to build out the NSPS. And I know that the vast majority of people attending this webinar are involved in emergency management or hospital response in some way. And we're all really familiar with the boom bust cycle of funding, right? That something happens and we get a lot of funding for it, and then time passes and the funding goes away. And certainly the same has happened with infectious disease funding at the federal level as well. And it's really hard to support and sustain systems when you're facing that kind of a cycle. Only the 13 level 1 facilities have had consistent funding at the federal level, at least directly from the federal level. I do want to recognize that many other level 2 and even level 3 facilities around the country have received some HPP and other support from their states. There's not a consistent architecture to it, but it's not to say that only level 1s have ever been funded. But, if you count up the facilities that Shelley, you showed on your graph with level 1s and known level 2s, that only gives us 62 beds capable of hospitalizing a patient with an HCID throughout the full course of their illness, if that illness is a viral hemorrhagic fever or similar pathogen. For a country of 360 million people, 62 beds just doesn't quite seem like the right number, and it's why we need to expand the level 2 facilities so much. As you know, you and I and others, again, we've gotten such great support from folks across the country on this. We have been trying to find out exactly what it costs to be a level 2 facility, to be a level 3 facility, and so. Again, having hospitals that have built that capability a while ago and sustained it, or trying to build it now, we're getting real numbers on personnel costs, training costs, PPE costs, et cetera. And so NETEC and the NSPS are trying to make those numbers clear. And then those numbers can be brought to Congress, can be brought to other stakeholders to define what we really need to advocate for funding for the NSPS. I think there's a lot of appropriate concern that federal funding alone is not going to get us to where we need to get to, and that we need to think about local and state strategies, regional strategies, private sector strategies. And I want to give a huge shout out to colleagues in Region 10 in the country who have been developing case studies to try and identify and broaden creative funding strategies. Again, even though outbreaks are more episodic than, say, trauma happens, unfortunately, most every day, and it's easier to make some of the cases for a standing trauma system. We know that infectious diseases will always be coming and going. We're not going to be post microbial in any sense in our healthcare system, and we have to identify what those gaps are now. I personally actually believe it's far more cost effective to fund a system steady state. You end up spending less in the long term if you keep the system funded rather than you go through this boom bust cycle. And again, the NSPS leadership, NETEC leadership, ASPR leadership have done such a nice job of continuing this conversation and trying to advocate. So, I think this really gets to how do you make this argument? Why do you invest in preparedness? And many of us have to go to our hospital system CEO or CFO and make this case, or we can try and go to our governmental leaders. What's the return on investment? Why would you spend this money at all? Well, I think if I weren't already a facility within the NSPS, I think a couple of things on the left are helpful. One is you are contributing to the protection of the workforce in your community. I think that, you started off this morning with such a nice remembrance of 9/11 and the threats that we face as a country, the fact that we had to come together. And there still are many of us that are there to serve our communities. I think there is a badge of honor, and maybe that can be shared between facilities that join the NSPS and their community leaders to showcase who really is investing in community protection. If you join the NSPS, you're not doing it on your own. I think part of the strength of what you and NETEC are building, Shelley, is a whole bunch of resources to make it much easier than it was 10 years ago when we were facing the Ebola outbreak. There are so many tools and resources and partnerships that no one is doing it from scratch, and it's much easier than it had been. I think the patient outcomes piece, we are still trying to gather the data to really prove this point and get it out there. But as you train your facility staff on infectious disease awareness, treatment, infection prevention, and control, the hope is that can bolster daily care goals. All of us have infection prevention and control goals. We all have nosocomial infection goals, and it can contribute to becoming more of a high reliability, safe care organization. So I think all those bullets on the left are really important, and they need to be paired with the cost of inaction. I think we are aware of what happens when a facility fails to contain an infectious disease outbreak, does not demonstrate that it can deliver the care that the community needs, and what that does for patient confidence, for employee and staff confidence, and ultimately, reputational risk. So I don't think you can make the case purely on dollars and cents alone. Infectious disease care is never going to be the thing that balances the budget for a healthcare system. But it is actually something that is a clear commitment to the community's health, is a clear commitment to partnership with local and state authorities. And I think it's been easier than it ever has been to do this with more support from NETEC, from the NSPS leadership, from the regional system, and others. The last thing, Shelley, I'm going to drone on a little bit, unfortunately, answer here, but we talked about the gaps and we've talked a lot about finance. I do want to mention just that I think there are two other gaps that are worth calling out. Both you and I have talked already in this webinar about EMS. I think EMS is a gap, and there's so many people, so many EMS leaders across this country. Dr. Alex Isakov as a whole team working on this. But we know that if you don't have the ability to safely transfer patients across hospitals, you don't have a system. And I think there are still planning gaps in different parts of the country for how the healthcare system interfaces with the public health system. We both need each other. We both have different expertise and roles to play. But I'm encouraged that both NETEC and NSPS have a lot of work underway in these areas as well.
All right. Thank you, Dr. Bittinger. So next we're going to go to our panelists. So I'd like them to come on screen. And I'd like to introduce to you John Harahus. He's the Emergency Preparedness Coordinator from the Geisinger system out in Region 3. And Chris Salmonte. So you'll see level 1 and level 2. So Chris Salmonte is from a regional treatment center, Johns Hopkins, and he is the administrator for the biocontainment program there. And then Geisinger, also in Region 2, is a level 2 facility in that region. So I'd like to invite them to both talk a little bit about background there and how they've really advanced the system. So I'll turn it over to you guys.
Perfect. Thank you so much, Shelley. Very excited to be here today to talk to all of you, get a chance to have a little bit of a conversation. So as Shelley mentioned, I am the administrative director for the Johns Hopkins Biocontainment Unit program. Our program was established in May of 2015 with the original Regional Treatment Center federal funding that came in response to the Ebola outbreak. Our program has grown immensely over, we're going to be celebrating our 10-year anniversary in the next 6 months, which is crazy to think about. But really our focus has been how we can utilize our own experiences to best partner throughout the region. And a big component of that was recognizing that early on during our initial period of developing our program, expanding our program during our first 3 to 4 years, we got to a point where we felt that, we felt ready to go. And we felt confident in our ability to manage a patient that came through our doors. But one of the things that we recognized very, very quickly is that, as mentioned already, any of these sort of infectious disease outbreaks can happen anywhere. And more likely than not, if someone is concerned that they might have something or is reaching out to a health department, they're going to go to the facility that they are most comfortable with, that they're closest to, that they feel that they are supported by. They're not going to type in where's the closest biocontainment unit and wander their way over there. And so from that extent, really starting in 2019, actually late 2018, we initially reached out to many health departments within our part of the United States and Region 3 to ask if we could collaborate in developing free on-site resources and education to facilities within our region, with the idea being that we wanted to prioritize frontline healthcare workers that would be experiencing these entry points firsthand in working with these patients, and creating a way in which designated state treatment centers, whose goal was to manage the overall capacity in areas that we may be experiencing multiple patients or would be likely where these patients would be seen firsthand, be in a place where they felt, one, supported, but two, could maintain that capacity. As we transitioned post-COVID, one of the things that was very unique and very exciting for us was this focus both at the federal level and I'll say again on the regional level to create a more dynamic preparedness response. And what I mean by that is really taking the idea of how can we partner with all of these different facilities at all these different levels within the NSPS to create a network of on-site partners, a network of virtual meetings and partnerships, and then also just putting faces to names. And so one of our goals early on was to figure out how could we put our face out there as much as possible. Instead, not just focus on, again, having our own house in order at Johns Hopkins, but how we could be a partner to the neighborhood and make sure that the other houses throughout our region felt comfortable in doing that. And so through that process, I had the very exciting opportunity to meet John. And then from there, honestly, our relationship flourished. So I'll turn it over to him to talk about his experience and sort of how we came together.
Yeah, thanks so much, Chris. So even going back before COVID, a BC time, we leveraged NETEC in a way that really helped us build our unit. So we have a level 2 unit in Pennsylvania. We sent a multidisciplinary team to a few of those level 1 centers and took some best practices and unit design ideas back to develop our unit. So even going back before our current relationship, we've leveraged these resources. We leveraged the website extensively, not only for up-to-date information about current emerging infectious diseases and other special pathogens, training webinars like this, but in fostering that relationship over more recent years with Chris and the team at our regional centers, we've toured one another's units. We're able to take things away from that. There's bi-directional information sharing. Chris has put together a regional meeting for our centers and other partners like public health departments to share information. So we have those meetings regularly, including one yesterday, where we were able to share information throughout the region. And policy review, we've updated a lot of policies and actually worked on developing a dashboard for our responder readiness and tracking that we've shared with Chris and the team as well. So again, working on bi-directional information sharing between our level 1 center and throughout the region. Chris has really fostered a good system within our region for people to easily reach out and get in touch with our regional center.
Well, it makes it easy when we have good partners to do that. And I'd be remiss if also not to include that we also in our region have the benefit of having a second regional partner with MedStar Washington Children's National as a regional treatment center program as well. So which allows us both on one hand to improve our overall readiness, but also have a partner with another perspective in order to improve our capacity and really partner on how we best approach different relationships within the region.
Thank you both so much. I think maybe if we can go to the next slide, we're going to build on what you all have been talking about, which is that amazing collaboration across a region with great partners. And you know, as we finished the previous section talking about, it's not just the healthcare system, but it really is the healthcare system, the public health system, and all of our key partners. And so I'm extremely fortunate to be able to introduce from Region 5, Jessica Gould, who is the Public Health Emergency Preparedness Section Manager for the Michigan Department of Health and Human Services, and Julie Bolson, who is the Director of Business Assurance for Corewell Health, and really a great example of, again, that public-private partnership collaboration. And maybe if I could ask you to share your experiences building on what John and Chris were talking about, how you've been able to work together so successfully in Region 5.
Yeah, thank you so much. I think our experiences in the region as a whole go back through, to 2015 and kind of building that regional plan for us. Originally, at that time, we only had University of Minnesota as our regional treatment center. And now we've added in Cornwall Health. It's been great. That's really allowed us. So we went back and re-looked at our ConOps for the region as a whole. Then we added in Cornwall Health, and we're really able to work with them to strengthen planning across the region to allow us to have a more robust plan. And so and to really talk about, since we do have the luxury of two RES PTCs, where do patients go and how are those decisions made? It allows to sort of give you that out a little bit. So it was great. We do work really well and often together. We have regular meetings with each other. We do talk pretty much all the time and can pick up a phone or send an email and get a pretty good answer right away. So on that, I'll hand it over to Julie so she can talk more.
Thanks, Jessica. And Jessica's right. We've worked together for a very long time, and we are fortunate to have a very close collaborative relationship with our state health department as well as with the GLHP. And so from a Cornwall Health perspective, we were in 2015 a tier 1 state organization. So we were one of the special pathogen treatment centers within the state of Michigan. And it was just a natural transition to move into a respect level 1 program when the grant became available. And so we have been able to work alongside with that respect designation, work alongside the state health department in really promoting education throughout the state. We recently were able to organize and complete a state special pathogen conference where we had, I don't know, maybe over 100 people that attended, all from various hospitals, EMS agencies, public health departments across the state of Michigan. And we talked about special pathogens. We talked about transportation. We talked about PPE, all of those hot topics that we have within caring for an HCID patient. We were able to come together in one location and really provide a lot of really good information for those organizations that might not be as prepared as what we would like to have them be. So we really are looking forward to continuing to work with our state health department and the GLHP in the broader perspective and with the RESPECT program in Minnesota to be able to help strengthen our response across Region 5 and really promote some of the education that's out there, not only from the NETEC website, but our expertise as an organization, and bring that out to some of the tier 2 or the level 2 and the level 3 organizations to help them become better prepared. So just looking forward to that ongoing collaboration with our state health department in really promoting this work and making sure that everybody is as ready as they can be all the time, no matter who walks through the front door.
And I did want to give a plug too. In the spring, we actually did an exercise as well. We did planning not just with Julie and her team at the RESPTC, as well as University of Minnesota, but we also had NSPS involved as well. So we had kind of all those players. We had multiple states within the region involved in that exercise, both planning and participating. And it was phenomenal. It was a really great, like 2 or 3 hour exercise, maybe even 4 hours, but it was a tabletop, virtual, but they made it really engaging and helpful. And, it shows that whole continuum of all of us participating, and really we walked through our new ConOp. So it was very helpful. So I just wanted to throw that in there.
That's fantastic. Thank you both so much. I think what we're going to move into now is just a couple of questions, and as is common in a webinar like this, time flies by and goes past before you know it. But maybe start with a question that was pre-submitted already, and maybe Chris, I'll ask you and Jessica to speak. But for a lot of folks on this webinar who don't really understand exactly how the system is supposed to work or how's it work, could you talk through the path of communication if we were to have an outbreak with national significance? So maybe Chris, what are you doing on the hospital side? How do you work with your health department? Jessica, how do you work with your healthcare organizations, and how does this weave together at the national level as well?
Yeah, that's a great question. And I think as a starting point, and I think this has been clearly already alluded to, is the importance of pre-positioning the private and public health partnership, because a lot of this is usually aligning both of those at the same time. And generally speaking from our own Region 3 experiences, really what we are doing, if say, for example, there's an area of concern regarding an outbreak, the first obvious mechanism is having those at the local level reach up through their own health department in order to best notify the rest of the region. So if we're talking about, say, for example, we have a concern of an outbreak in Virginia, going through the state health department level, and then notification throughout those state health departments, as well as through ASPR, since we're talking about interjurisdictional activities, to then bring in both the DC Department of Health, the Maryland Department of Health, and both of our facilities. Well, 3 of our facilities, both of our programs, a better way of saying it. And a lot of times, once that notification is done, our real focus is then determining what is the right place for the patient and what is the capacity of care that that patient needs. And so from that standpoint, what we'll usually do is assess what are the needs of the patient, how we can best transport that patient to the location we need to get them to, especially from a level 1 standpoint. And then also, depending on the situation, how we could best partner with highly capable level 2 facilities as well, and seeing what their capacity is if they're able to partner with and bringing them in. So a lot of times there's flexibility in terms of where the final destination for the patient is, but the big piece for us, and in most scenarios, I would guess, is to 1, engage public health early, 2, to involve federal agencies when interregional activities are required, especially from a transport standpoint, and then more specifically, bringing in as many clinical partners as possible when we're talking about the final disposition for those patients.
Awesome. Jessica.
No, I don't have a whole lot to add. Chris did a great job answering the question. We have normal communication, whether it's through reportables, like, you have reportables that you have to do through epidemiology, right? And those are there for a reason, because we then can report those up to the CDC and our other federal partners. And that allows, those are the normal things, whether it's measles or something else, right? So I think that would be a big suggestion.
Awesome. Well, thank you. Thank you both so much for that. I'm going to see if I can maybe sneak in 2 questions before we get to the top of the hour. John, I'll ask this one to you as someone, very, very much involved in a healthcare organization. We all know that healthcare organizations themselves, and certainly the providers, the nurses, physicians, others, are feeling overwhelmed. And how do you make this a real capability? How do you really sign up in the environment that so many healthcare organizations find themselves in right now?
Yeah, thanks, Paul. That's a great question. We have a team that's very much like family. So it's a voluntary process to be on this team. We've advertised the unit via various methods. We've had open houses so staff can come and tour the unit. We've had articles go out via internal and external media to describe the unit and what it does. But we really rely on that team, that family, to assist with decision making as well. We have a multidisciplinary group. It's a shared governance unit, but we value the feedback of our team. For example, we did a full-scale exercise in January and collected staff feedback as a part of the after action report and improvement plan process. And we're acting on a lot of those items that were identified by the staff. We don't just put that in a folder and let it collect dust and it goes away. So we empower the staff to help with that decision making within the unit, identifying issues. We have an engaged leadership team here as well. And I know some facilities aren't as fortunate as we are, but explain to your leadership what you do. They may not understand. Involve them in the planning process. And explain the importance of it. One of the prior slides mentioned, a little bit of preparedness goes a long way. Look at the ramifications if you're not preparing for this and you're not engaging people, and you have one of these patients show up at your facility, and you have potential for staff exposures or other adverse consequences to present. So we're just very respectful of our staff members, of our team, and appreciate their engagement within the unit. But using them as we're coming up on 10 years, we have a 10-year anniversary party coming up, and we offer educational topics for the team as well. We've engaged Chris to speak about the NSPS system, had our FBI WMD coordinator come to speak. One of our EMS transport agencies is coming to speak as well. So trying to keep various speakers and topics available, bringing them in to engage our staff and educate them as well. So just a few strategies that we've used.
Shelley, do I have time for one last question, or are we hitting the hour?
I think we're hitting it. I've got a couple of things to cover on continuing ed yet. So
Fair enough.
as expected, we just weren't able to hit all the answers to all the questions. So we definitely, you guys, really appreciate the intentful questions that you provided. I was trying to answer quite a few, but we will continue to get those answers to you and put those together in some sort of compilation. And as we've noted, we'll have these slides, we'll have details, the webinar recording out on our website in the very short time frame. So I want to cover a couple things here before we finish. If you're interested in a technical support service piece, which I saw a lot of questions in the chat, please go to netec.org or info@netec.org. We will connect with your regional treatment center and partner, and we'll get you the answers and connection to your questions. If you want to do the self-assessment tools that are out on our website, please go do those. That will help you better understand kind of where you are, and then you'll know what to ask for, right, from your regional treatment center as far as support. We have lots of online education and training, and some are connected to continuing education, so please check that out. We've got a whole resource library. Don't start from scratch. Find the things that you need out there, and if you can't find it, click on I have a question, and we'll get back to you. We also have an e-newsletter where we're constantly sharing updates about what's happening and what's new. Quick reminder, this is how you can get help from us. So please reach out. That's what we're here for. These are our social media handles, so please join those so that you can constantly stay updated on what we're concerned about, what's happening in the world, and what's new as far as preparedness goes for special pathogens. Thanks everyone for attending today, and we hope that you all will consider being part of this network, and please reach out for any questions. We've got answers, so let us know how we can help. Thanks so much. Bye now, and thanks to our panel.